Okay, so the next part of clinical testing are the very, very useful tuning fork tests. These are well over 150 years old tests, but they are extremely useful. And they give us a very, very good idea both about the presence of hearing loss and the type of hearing loss. Now, a tuning fork is usually a metallic structure that has a base, and it has the two prongs. When struck, and we normally strike it on the soft, like your elbow or your knee, and it vibrates. This vibration can be heard both by air conduction, and if you put it on your mastoid, it can be heard by bone conduction. So this simple device can allow us to assess both air conduction and bone conduction. And there are various tests which have been devised for enabling us to assess hearing of each side one by one. And we look at 3 of these tests. The first test we are going to do will be based on certain principles of tuning fork testing. The first principle is that in a normal hearing person, air conduction is better than bone conduction. That is very important for you to realize, that both ears are essentially equal in terms of bone conduction, but in a normal person, his or her air conduction is better than bone conduction. In conductive hearing loss, and conductive hearing loss is the type in which the conduction has been affected, you find that the person's bone conduction becomes better than air conduction. Because air conduction necessitates amplification, and if that amplification is blocked in conductive hearing loss, then bone conduction paradoxically becomes better than air conduction, and this requires at least 25 to 30 decibels of hearing loss. In sensory neural hearing loss, if someone's inner ear is weak, let's say by 20%, you'll find air conduction will still be better than bone conduction. These principles are what underline our interpretation of tuning fork tests. The first test that we do is called Schwabach's test. Schwabach's test basically is the comparison, and once again I will demonstrate on our subject, with the comparison of the patient's bone conduction with the examiner's bone conduction. And of course this you can only do if your own bone conduction is normal. So there are 2 ways of doing it, but the simple one is that you strike the tuning fork and you put it on the patient's mastoid and tell the patient to tell us whether he can hear it and tell us when he stops hearing it. Once it's gone, you put it on your own mastoid and see whether you can hear it. So I couldn't hear it. So what it meant is that when the patient's bone conduction stopped, even my bone conduction stopped. So now I will do it the other way around. I will put it on my mastoid and wait until I stop hearing it. Once I have stopped hearing it, I will then transfer it to the patient's bone mastoid and ask him, can he hear it?
I can't.
He can't. What this means is that, of course, our subject is normal, then the patient's bone conduction and my bone conduction are equal. And if I'm normal, he is also normal. This is called the Schwabach test being normal, meaning his bone conduction and my bone conduction is the same. Now, the other possibilities are that if someone has conductive hearing loss, the patient's bone conduction will be better than the examiner's bone conduction. And the reason for that, I explained in the previous slide, is that the bone conduction becomes better than air conduction when there is conductive hearing loss. If, however, the patient had sensory neural hearing loss, then his bone conduction would be shortened than the examiner's bone conduction. This is what needs to be done. Remember one thing, although we are putting the tuning fork in Schwabach's test on one mastoid, actually both ears are being stimulated. It's not that the sound is going only to one cochlea. The sound is going to both cochlea. So you're actually assessing the best ear. So although we do Schwabach on either side, there's a bit of an error because you sometimes don't know which cochlea the person is answering from. Because there is the sound, when the sound is applied to the skull, it goes to both cochlea at the same time. The next tuning fork test is called the Rinne's test. Now in Rinne's test, what we do is, I'll demonstrate once again, you have to compare the patient's own bone conduction and air conduction. And how you do it is that you again strike, you can strike it on your knee, once it's vibrating, you put it on the external ear and ask the patient or the subject to tell us when he stops hearing it. So Mr. Zewert, please tell us when it stops.
There.
It has stopped. Then you transfer it to the mastoid. Can you hear it?
Yes, I will. Yes. Yes.
Okay. No, do you feel it or do you hear it?
Yeah, just it again.
Okay, we'll do it again. Sometimes this is subjective, so we can do it again. So, can you hear it?
Yes, I can hear now.
Okay, tell us when you stop hearing it.
It's gone.
Gone. Then you transfer it to the mastoid.
I can hear something.
You're not sure.
Yeah.
Okay, no problem. In this case, the subject is not sure, so we do it the other way around. You first put it on the mastoid and tell us when you stop hearing this.
Can't hear.
You can't hear it. Then you transfer it to the external aortic canal. Can you hear it?
Yes.
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 That, in fact, when there is confusion, that's why you do it on both sides. Now, what this showed was that in this case, the air conduction was better than the bone conduction, which is what we expect in a normal person. Once again, if you look at the slide, that if air conduction is better than bone conduction, that is called Rinne's positive, and that is normal. If the person has conductive hearing loss, then what happens is bone conduction will become better than air conduction, and that is called Rinne's negative. If the person has sensorineural hearing loss, as I said earlier, air conduction would still be better than bone conduction, and this would be called Rinne's positive. It means that if someone has Rinne's positive, he could be normal or he could be having sensorineural hearing loss. But remember, by doing Schwabach, we may have found out whether there is or there isn't hearing loss. In Rinne's, the biggest concern that we have is of something called Rinne's false negative. Now, Rinne's false negative is something that we have to look at hypothetically. And once again, I will make a hypothetical demonstration because Rinne's negative occurs when there is unilateral hearing loss. Let us assume that our subject's right ear has sensorineural hearing loss. Now, what would happen if I did Rinne's? If I did Rinne's, this is hypothetical. If I put it on his ear, because this ear has sensorineural hearing loss, the patient would say, I can't hear the sound. Then, when you transfer it to the mastoid, the sound would actually go to the other ear, and he would say, I'm hearing it. And one would think that this is Rinne's negative, and one may think that it is conductive hearing loss. But the reality is that he has heard with the other ear. So, this situation is called Rinne's false negative. The interesting thing is, when we perform Rinne's, we cannot know is it true negative or false negative. That we clarify by doing the next test, which is called Weber's test. Now, Weber's test is done by striking the tuning fork. Once again, I'll demonstrate. And in this case, you compare the patient's bone conduction of each ear with each other. So what you do is you strike the tuning fork and put it in the middle of the forehead and ask the patient, do you hear it in the middle or do you hear it louder in one ear? So normally, where do you hear? In the middle. In a normal person, the bone conduction of both ears is supposed to be roughly equal. So the patient will hear the sound in the middle. That is called Weber central. Now, if someone has conductive hearing loss, for example, if I block this ear, I've blocked this ear, I've blocked it, and I've given Mr. Zivo left-sided conductive hearing loss. And if I do Weber, which side do you hear it louder, Mr. Zivo?
Side.
Back side.
The blocked.
Because of conductive hearing loss, which I did simply by blocking the ear,
Okay.
the bone conduction becomes better than the normal ear, so he'll hear it louder on that side. That is called Weber lateralization. That lateralization occurs on the side which has conductive hearing loss. Now, if he had sensorineural hearing loss, let's assume that this ear had sensorineural hearing loss, then of course he would hear back on the other side. And this is what the value of Weber is, to differentiate conductive and sensorineural hearing loss. So that if there is sensorineural hearing loss, Weber will lateralize to the better ear. And this helps us to know if it is Rinne's true negative or false negative. Okay, let's take a break there.